Nelson down. Okay, try it.
Yeah, I'm just aware that there are some numbers on here that might be a little bit small. So I apologize for that, but luckily you have a great big screen. So thank you very much for having me here this afternoon. One of the things that we really value at the hospital is the opportunity to come out and speak to the people that we serve and get input back from you. So the questions that you asked me today, I take back and we talk about them and we try to find better ways to get the information out. A lot of the information that I'm going to give you today, you are not going to see in the newspaper or here on the radio. And the reason for that is that we are working very closely with the Ministry of Health Capital Branch, and they don't like to see surprises come out in the media. And so we've been sort of flying under the radar with the media, not doing a whole lot of direct updates, but instead choosing to speak with people in groups like this so that you can ask the questions that you want to hear. So you feel free to share this information, just please don't post it in any newspapers, because I had one of the videos that I sent out, someone sent directly to the Minister of Health just before Christmas, and luckily she thought it was very nice. So that was great. Okay, I'm going to try and push the buttons here and see what happens. Nothing.
Let me first get rid of this stupid pop-up. Right, let's do that. Still not?
What if we just tap? There, we're just going to tap.
You got it.
How's that? I'm not very technologically savvy. So I wanted to start off by showing you numbers. These are numbers that were our average numbers pre-COVID. You have to understand during, how many years was COVID? 2020, 2021, our numbers dropped significantly. Nobody really wanted to come into the hospital. But these were our average numbers previously. So we're looking at fairly significant emergency visits, about 33,000 visits a year. Prior to COVID, we were up around 37,000 visits a year, and that was fairly common, about 45 to 5,000 surgical procedures. And the one that always gets the people are the number of births that we have. We always think of ourselves as an aging community, and that is true to some extent, but for those of you who moved up to the area, how many of you had children follow you up here, who now have grandchildren in the area? Yeah, very common. And especially during COVID, the population in our schools went up significantly. I wanted to talk to you before I get into the hospital development. I just wanted to bring your attention to two new things that have been happening at CGMH. The first one is our clock, our estimated wait time in the emergency department. So quite often people will say, should I go to the emerge? Should I not go to the emerge? Can I go to the after hours clinic? Can I just call my family doctor? This can help you with this. I want to stress that if you are having chest pain or blurred vision, or you have broken a bone, do not look at this clock. Come directly to the emergency department. However, this clock will show you, it's on the website of the hospital, so cgmh.on.ca. You will see on the, can I do this? This is the menu on the home page. You will see the clock on the menu at the home page, and it will, okay, so the issue is it doesn't go back. Oh, there we go. It will tell you the estimated time to be seen by a physician. It will tell you how many people are in the department at the time, how many people are actually being seen, and how many people are waiting. You will also see a graph on there that will tell you when the least busy times are historically. Now, this is only as good as the minute that you look at it, because something, really big could happen between the time you leave here and the time you go to the emergency department. But it does give you a bit of guidance. And I think the important thing to remember is that all emergency departments operate on a triage basis. Those people who are most ill, most at risk of losing life or limb will be seen before anybody else. And so we provide you with a triage score. You're scored by the triage nurse. You go into the system, and the system decides who comes next. No matter what you think, if the triage nurse is a little bit grumpy that day, she is not holding you back just because she doesn't like you. So that's new. The next thing that's new is a program called My Healthcare. About 8 to 10 months ago, Collingwood Hospital joined with RVH in Barrie, with Midland Penetang, and with Orangeville Headwaters Hospital to create one shared electronic medical record. This was done for several reasons, one of which is that eventually the province someday, hopefully before we all pass away, will connect all records together. But they're relying on hospitals right now to do that work themselves. So we chose a group to work with. You get economies of scale. You can actually merge your IT departments so that you can have resources that you share between. But My Healthcare is a portal that you can go onto. You have to register. And once you're registered, you can see your upcoming hospital appointments, okay, not family doctor appointments, hospital appointments at any of these hospitals. You can see lab results, you can see notes from surgeons, you can see reports from radiologists. All of that is available at My Healthcare. So we're hoping that people will start using that more and more so that they can get the information in a timely manner. I don't know how many times I've had calls from people who said, I had my X-ray or my CT 4 weeks ago, and you haven't sent the results. Well, most likely we have sent the results. Your family doctor just hasn't had a chance to get in touch with you or couldn't get in touch with you. Now you can see this on the portal. So here's what you're all here for, I am quite sure. You want to know about what's happening with a new hospital. So I'm going to take you through the story. I'm going to tell you where we've been, where we are today, and where we're going to go. So the biggest story with redevelopment is that it's all about population growth and lack of appropriate space within the existing building. The emergency department alone, you saw the numbers for emergency, 32,000, that's lower than what we usually do. The emergency department was built in the 90s for 15,000 emergency patients a year, 15,000. So we are working in a space that's half the size of what it should be. If you've been in the hospital lately, you'll notice that we've spilled the emergency department out into ambulatory care and into see and treat, and we just kind of keep moving it out more and more and more so that we can treat the volumes of patients that we get. We also generally get a fairly high triage score patient. Pre-COVID in particular, our family health team was very good at making sure that they took those less urgent patients and dealt with them in other matters. So we were regularly getting 60% of the patients who came in the emergency department were patients who really had to be there. So they were triage scores at 1, 2, and 3. The 4s and 5s were going to the family doctors. Now, with the population growth, we're having a little bit of a difficulty in keeping up with the population and family doctors, but we're continuing to work on that. The 80% of the hospital is a 1950s build. We renovated that entire building in the 90s. It took us 3 years to renovate it. We renovated 80,000 square feet of space and added another 40,000 square feet of space. After that, we started adding modular buildings, and I don't know how many square feet we have now, but we have 5 modular buildings on site. The problem with the 1950s infrastructure is that it's very dense. So you can't go through and blow out walls and have those wide open sight lines that you need in modern healthcare. Our really big problem is what we call our slab to slab height. So the floor to the ceiling above. In many places, we're lucky if we get 8 feet. There's some places where we have 10 feet, but if you're tall and you're walking through the hospital, especially in the basement, you have to be careful not to hit your head on the signs. A modern hospital is supposed to have a slab to slab height of 16 feet. You can't move those slabs up and down. It doesn't work that way. So it's very difficult to do that, but the population growth has been extraordinary. Collingwood will double its population in the next 20 years, less than that now, probably about the next 15 years. The Blue Mountains is the 5th fastest growing community in all of Canada. Number 5. Wasaga Beach was up there before. I think they're about 13th now, but Wasaga Beach between 2016 and 2021 grew over 20%, where the national average for growth was 5.8%. So we are growing quickly and we are having trouble keeping up with it. Just keep pushing. Can you still hear me at the back? Perfect. Okay. So I wanted to spend a little bit of time on where we've been. So back in 2016, for those of you who were living here in 2016, you may remember that we did community consultations all through our service area. So the Blue Mountains, Grey Highlands are included in our service area with Collingwood, Wasaga Beach, and Clearview as well. We went to all our service areas, we talked to the population, we put together what was our stage 1A and B, which was our master plan and our master program, which outlined the services that we felt were needed both in 2016 and 20 years out. We looked at population projections. We basically took into account how healthcare was changing. We put that into a report and we submitted it to the ministry in 2016. In August of 2021, the minister arrived on site in Collingwood to make a big announcement. We were disappointed that the minister announced a renovation and expansion on the current site. We knew, though, that we had a good business case. The great thing about what she announced was she announced a $15 million planning grant. So the $15 million was not to build a new hospital, because I don't even think you could build an emergency department with $15 million. But it was all of the planning money that we would need to go through all of the 5 stages of planning, all given to us at one time. So we knew the government was committed to that project. What we had to do was put together the very best plan, the very best business case to make sure that we presented the hospital that South Georgia Bay needed. So we hired some very good consultants. We hired Agnew Peckham as our consultants, who have done dozens and dozens of these projects with the ministry, and then Perkin Architects, who are known for the public buildings that they built. And we got right to work. Basically, we knew we had to prove them wrong. So these are the 5 stages of redevelopment. We are now at stage 2, which is the functional program. The functional program is the most important piece of all of the planning that has to be done. It's the roadmap that shows us what type of facility we're going to get and what types of services we can provide within that facility. Stage 3 and 4, we have been told will actually go together. So that's the preliminary design, the architectural drawings, and then all of the documents so that we can send this out to RFP for tender to hire a contractor. And once we get to stage 3, Infrastructure Ontario, who is the funder of this, there's the Health Capital branch who makes the decisions on what programs and things we're going to have. Then there's Infrastructure Ontario that works with the Treasury to make sure that they have the money in place to do these projects. They have about 40 capital projects on the go right now. You can see twice a year, 3 times a year, they actually publish a market document that goes out that lists all of the projects that they have on the books, what stage they're at, what budget they will have. And that goes out to all the major contracting firms, the architects, the engineers, the construction firms, so that they can start deciding what they're going to bid on. We have been told by Infrastructure Ontario that we will be ready to have shovel in the ground in the spring of 2027. Now you say, oh my God, 2027, that's forever. Well, when you have to go through all of these stages and you need to get government approval at each one of these, 2027 does not seem that far away from us as far as how are we going to get all of this work done. Excuse me. So this is stage 2 broken down, and you can see that we launched the project in October of 2021. The first part, which is the functional program, basically looks at those services. It takes all of the information that we had in stage 1 and it updates it 5 years later. So when you think about it, if we had done stage 2 pre-COVID, we would have been in a bit of a pickle because we would not have seen this population expansion coming to the rate that it was. But each of these areas, we're broken down into 18 teams of professionals. So for example, the emergency department planning team would have in it an emergency department physician, emergency department nurse, a clerk, a respiratory therapist, a pharmacy technician, a radiology technician, somebody from our facilities team, somebody from dietaries, somebody from maintenance and housekeeping. A patient advocate is on each one of these teams so that they can bring the patient perspective to the planning. So we've got these 18 teams that are looking at every corner of this building and providing input back into the framework. So we finished the functional program. Some of the things that we see in the functional program that weren't in the first program, in the stage 1, is that we see a huge need for inpatient mental health. We have been always relegated to using regional inpatient mental health beds in Penetang Midland or over in Barrie or Aurelia. What happens to those regional beds is those hospitals, when they get into trouble, they use those beds first. They don't necessarily keep them for the regional nature. So we're making a business case to the ministry that we should have an inpatient mental health unit. We're suggesting that we partner with Waypoint, which is over at Penetang, so that we can make sure that we get the appropriate human resources, health human resources, to be able to run that department. Where are you going to get a psychiatrist or multiple psychiatrists, because they're very difficult to get? Psychiatric trained nurses to work in those units. If we partner with someone else, we're going to be much better off in our training and making sure that all our processes and protocols are in place. And so we're looking at that. We are also looking at far more inpatient beds than we had originally thought. So that has grown. In fact, the building has grown quite significantly, almost by 50% over what we had in the original stage 1. So we have now finished what we call the architectural block schematics for the building. So the block schematics show where the rooms are, how each department interfaces with another department. So important department adjacencies are like the emergency department has to be right next door to diagnostic imaging. You don't want to have to run to the other end of the hospital with a critically injured patient in order to do a diagnostic modality on them. You want to have them side by side. We want to have our intensive care unit on the same floor as our operating room, so we're not taking post-surgical patients that may be not very stable down an elevator. It's very difficult to resuscitate a patient in an elevator. So all of that is being taken into place. And what we have actually done is that we've done this work both for what we call the brownfield site, which is the existing site, and for a greenfield site. So we're prepared for anything. Some of the key issues that we need to address, as I talked about, space. We need more space. Think about if you've ever been into our hospital, walking down the hallways, you can't put two people in a hallway doing this. In fact, during the height of COVID, before we got masks, we used to walk down the hallway. If you saw someone coming the other way, you would face the wall and go along the wall. The other person would turn the other way, so we didn't actually come into close contact with one another. That's how narrow the hallways are. They're very low. Our patient waiting areas are very small. Our registration areas is also our lobby, is also our gift shop, is also our waiting area. You know, every area in the hospital is for 3 or 4 different reasons. We want 100% private rooms. In fact, that is a basic standard now in any new hospital that is being built. And that's all to do with infection control. But when you think about it, it's also better for the patient because you can have family interactions in a private room. You can have a family member in that room the entire time helping the nursing staff. And if any of you have had a family member in any hospital anywhere recently, you will know you don't want to be leaving them alone. We want to look at increased focus on infection control. So all of the surfaces that we put into this new build will be based on infection control. We did a pilot project back in 2019. It was on the medical floor. We didn't get the surgical floor completed because of COVID. We equipped our rooms with copper-coated toilet seats. Now, that sounds ridiculous, but copper coating does not allow any microorganisms to grow or even to live. So as soon as they hit that, boom, they're done. We have ultraviolet lights in our bathrooms and all of the patient rooms so that when the door closes, the ultraviolet light comes on, bathes the room in ultraviolet light to basically kill all of the bacteria. We have ozonated water in our sinks. We have self-cleaning sinks that when the person has finished washing their hands with them and they walk away, the sink then 15 seconds later cleans itself again. All of these types of things are based on infection control. We have done some of the most advanced infection control work anywhere in Collingwood. In fact, when the Sick Kids Tower was announced, the Ministry of Health sent the people from Sick Kids up to see us to show them what we have been doing in infection control. We want to have a focus on wellness. So wellness is inside the building and outside the building. But when we talk about wellness, it's the air that you're breathing, the water that you're drinking, the food that we're providing to you. It's the light that's coming in. It's the areas where people can go and just sit for a minute and not have someone talking to them. We want to make sure that I talked about department adjacencies, and we want to make sure that this building is designed for future expansion. Anybody who's been involved in a hospital building will know the minute you move in, it's too small. So you want to make sure that it's easy to expand it. So we have 6 planning principles that we layer over top of everything that we do. The first one is high quality and safe patient care. So we want to have evidence-based care, and we also want to make sure that there's timely access to care. For example, we have a satellite dialysis department in Collingwood. It's a satellite of Aurelia Soldiers Memorial Hospital. And so patients go to Aurelia. The nephrology team there works with them. They get them on a stable regimen. Then they send them to Collingwood when there's a space available. And then the nephrologist comes once a month to check on them. We want to move that to cancer care. Right now, with cancer, we do diagnosis, we do surgery, we help with the lab tests. So we basically use virtual visits with the oncology department in Barrie to determine whether you can start your first round of chemo. We do the port disconnects at the end. What we really want to be able to do is to do chemotherapy in Collingwood as well. We have no safe space to do that right now, but it would be the same thing. You would go to Barrie, you would go meet with the oncology team there, you would get on the standard regimen, you would come to us, and then we would implement it. We want to make sure that we have exceptional care for all. So an exceptional experience means that we want to create the space and the amenities that are accessible, that are welcoming, that support a diversity of culture and ages, sexual orientation. We want to make sure that everyone who comes into the building not just the patients and the visitors, but the staff and the volunteers who have to work there every day have an exceptional experience. We want to make sure that we have a healthy and inclusive workspace. So again, promoting wellness for our staff. We want integrated education and learning. I'm not sure if you know that we are actually a teaching hospital. We are credentialed with all 6 medical schools in the province of Ontario, and we accept residents and students from all of those medical schools. So we want to be able to build upon that. We want to be technology enabled whenever we can. So virtual care whenever it's appropriate. We have a lot of patients that come from the Muskoka area, Huntsville, for example, with shattered hips. And it used to be that they would have to drive back and forth to see the orthopod after their surgery. Now we do that virtually to make sure that that patient isn't on the road all the time. And we want to be flexible and adaptive with the spaces we design. We design a space in this existing building, and it's that way until the next crisis comes along, and then we redesign it and make it something else. We put walls in, we take walls down, we put doors in, we take doors out, we take rooms, we cut them in half, then we cut them in half again. So we want to make sure that it's easy for us to do that as we continue to grow. So what have we found through all of this planning? And it has been a long 18 months of planning. We have found that, surprise, surprise, there are design compromises if we build on the existing site. So the existing site has 12.4 acres. It has 1 path in for the helicopter. We should be able to have 2 paths. We can't do that there. The only way that we can add onto that building is a vertical tower on the east end. The vast majority of the existing building is not suitable for patient care. We could put some ambulatory care clinics in there. The rest would be storage and offices. The tower would have to be 8 stories. And when you look at the size of the stories in hospital, that would be equivalent to a 11-story tower on that space at the end of that building. We know that the construction and the renovation would take at least 8 years. That's twice as long as what it will take to build a new hospital. We know that it will be tens of millions of dollars more to build on that site. So we have told the Capital Branch this, and they have said, that's a surprise to us. We think maybe you should think outside the box. And that's why now we have moved so much more focused onto the Greenfield site. We basically have all the information we need on the Brownfield site to show them the business case does not support building here. It's not good for the community. It's not good for the patient. It's not good for anyone. So part A is basically all done. We're working on part B. Whoops, there we go. Now, location. So I'm sure you have heard about the 30 acres on the Poplar Side Road. 10 years ago, no, 11 years ago now, I first met Mr. DePoche. They sent me to ask Mr. DePoche if we could have 12 acres of his property for free. And he said, I think that's a great idea. Why don't I give you the 12 acres right beside Georgian College? And we went, yes, great. And we realized 12 acres isn't nearly enough. And they sent me back and they said, can you get 15 acres? So I went back and I said, John, you know how you thought 12 acres was such a great deal? Well, how about 15? Yes, 15. If you need 15, you can have 15. Then it became 20, then it became 25. And then they sent me back to at 30. And I said, this is it. I am not going back by myself again. So it has been 10 years working with John DePoche, who has been nothing but generous to us. He owns 130 acres on the Poplar Side Road, immediately east of Georgian College. The Georgian College property was also his property initially, and he gifted that to Georgian College. He continues to hold that 30 acres for us until we can get the permission from the Ministry of Health to be able to build there. So one of our big stumbling blocks on that property was that we did not have zoning for it. That property was zoned commercial or light industrial. And a hospital did not fit into that zoning parameter. The town of Collingwood has been redoing their official plan. They made no move to rezone that property for us. Mr. DePoche came to our rescue last year and designed a health and wellness village that he thought would supplement the hospital and would make good use of that property and also support what we were trying to do. In order to build the health and wellness village, he needed to get a ministerial zoning order. He took the entire 130 acres, so our 30 acres included, threw it all into one package and said to the government, we need a ministerial zoning order on this property so that we can work with it appropriately. He spent millions of dollars doing that. We got the ministerial zoning order, and I say we because we were just riding on the coattails, hoping beyond hope that we would get this MZO. We got that last summer. It was ratified by the town council in October. There were other things that happened in between, but we're just going to forget all that. Doesn't matter. We got the ministerial zoning order. That took away that huge hurdle from us because we could not say to the capital branch that we had a viable building site until we had something that was zoned to be able to build on. So suddenly we have a viable building site. It's 30 acres. It's, you know, more than twice the size of where we're building. We've got a plan for a less expensive, although still very expensive building. And suddenly the ministry is saying, yeah, okay, let's get over here. Now we're talking budget. The budget has gone up substantially through inflationary costs. So all of the other projects that Infrastructure Ontario is working on have also increased due to inflation. But we have the double whammy of also having that population increase. All of the new building standards for hospitals that are related to COVID that are significantly increasing the size of the building. So now what we're working with the government on is to say, we need more money. They had us in at 499 million. It's going to be significantly more than that, but we still believe we have a very good case to make that happen. We are not going to give up until we get the appropriate hospital out on a greenfield site. It's that easy. It's just not, it's not going anywhere else. So I have to stress that the government has the last word. And there may be a time where we come to you and say, the government's not listening. We need you to help us make them listen. But this is not the time. Right now, we have a very, very good relationship with the government. We talk to them on a monthly basis. They know exactly what we're doing. And so we feel that we're in a good position. So if we move from the Hume Street site, what will happen with that? Most people say, oh, it could be turned into long-term care. Well, you would still have patient rooms that had bathrooms in that you couldn't get a wheelchair into in there. That building is really not going to be good for anything. And so we believe the best thing to do is to make it a community benefit and gift it to the town of Collingwood because CGMH owns that property and that building. Gift it to the town for affordable housing or long-term care, expansion of hospice, expansion of Sunset Manor, whatever is the best community benefit. We're not going to let them sell it to a developer. I mean, if it's going to be sold to a developer, we're going to do that and take the money. But we really believe that there's some good use for that. So all that being said, what's the future look like? We have probably one of the most innovative teams I have ever seen in our medical staff, in our physicians, and our frontline workers. They are constantly coming through with new and innovative projects that are not seen at hospitals our size anywhere. We think we're the little hospital that can and does. We make things happen because we have such significant support from our donors in this community. We have a simulation program that draws rural physicians from, the United States, from Western Canada to come and learn what is the best practices for difficult situations in a rural hospital. Resuscitating a patient in a rural emergency department is not the same as resuscitating a patient downtown at St. Mike's. You don't have the same staff, you don't have the same specialists, you don't have the same equipment. So we teach it differently. We specialize in teaching rural medicine, and we have physicians on our team who are known across North America as experts in their field. And we believe strongly that if we can get them into a facility that is designed for healthcare in the 21st century, they will become even more innovative. So I know I'm not allowed to talk about fundraising here, but this is something that you need to know. In order to get this hospital built, there will be a local share component. Right now, the local share is sitting at $100 million. It may be more than that, but we're looking at $100 million right now. In order to get the approval from the ministry, we have to be able to demonstrate to them that we can come up with 10% of all the construction costs, 100% of all of the money needed to equip and furnish the building, 100% of all of the site development costs. And we think, for example, that by being directly associated with the health and wellness village on the Poplar Side Road that Depoche Management is going to build, we will be able to share infrastructure with them and cut our costs significantly down. We also have to pay 100% of the costs for any areas within the building that the ministry decides are revenue generating. Parking lots, cafeterias, gift shops, foundation offices, that's all 100% as well. We have $27 million committed to date, just very quietly. And within the next probably 12 to 16 months, you will see us out publicly raising money for the building. Right now, we got an MRI dropped in our lap in December, yay, except we need to raise $5 million in order to buy that. So we're focused on that right now. So in ending, I just wanted to thank you for coming out to hear today about your hospital. Please make sure that if you have questions, you call the foundation office, you call me, you talk to someone who can give you the right answers, because I know there are so many questions out there. But spread the word that we're not just sitting back waiting for something to happen. We are really working hard to advocate for this new hospital, and we are determined to make sure that it's going to happen. So that's the end of what I have to say, but I'm happy to take your questions. Thank you. Any questions? Pauline. Maybe I should turn this.
Okay. She has.
Yes. No, only from when it was implemented. Yeah. And you know what? I gotta say, a little hard to navigate right now. They're continually trying to kind of upgrade it and things. I found it difficult to navigate. It took a few tries. Any other questions? Okay. Well, thank you very much for your time. I appreciate it.